authors have no financial interest in the material being presented. Refractive surgery in keratoconus. Are you serious? Keratoconus is a progressive corneal thinning disorder which demonstrates irregular astigmatism leading to visual distortion. It is well proven that corneal collagen cross-linking, CXL, has been successful in stabilizing keratoconus. But can we achieve more than just stabilization? Let us look at Swati, who presented with progressive moderate keratoconus with visual acuity of 20/80 and pachymetry of 480 microns. Swati underwent a Dresden protocol corneal collagen cross-linking. As we can see, at 5-year follow-up, keratoconus was stable, and in fact there was a slight improvement in topography. So as doctors, we were very happy, but Swati was not. Swati still had low spectacle-corrected visual acuity, and unfortunately, she was not tolerating contact lenses. Then we realized that many of these post-CXL patients do not achieve good functional vision, especially when they cannot tolerate contact lenses. An ideal treatment for keratoconus should involve both stabilization and visual rehabilitation. In an editorial published by our group, we called this concept as Collagen Cross-Linking Plus. CXL Plus involves combining corneal collagen cross-linking with refractive procedures such as topography-guided PRK, transepithelial PTK, intracorneal ring segments, or phakic intraocular lenses to improve vision simultaneously. So let's understand the concept of CXL Plus with few examples. This 21-year-old boy was diagnosed to have mild progressive keratoconus with vision of 20/40 and a corneal thickness of 483 microns. Back in 2009, in a pilot study, we published that CXL can be combined with limited topography-guided PRK to regularize topography, which became popular as Athens protocol. In our series, topography-guided treatment reduced corneal irregularity and resulted in better functional vision. Further on, we published a randomized control study comparing this new combination approach of Athens protocol to CXL alone by Dresden protocol in 30 eyes each with minimum follow-up of 2 years. Athens protocol group demonstrated statistically significant improved visual outcomes and topography indices as compared to collagen cross-linking alone group. It is important to note that the role of the topography-guided PRK is to improve the refractive surface of the cornea and not to treat refractive errors themselves. Minimum pachymetry of 450 microns and restricting ablation to less than 50 microns is essential to maintain the integrity of the cornea. Our patient underwent Athens protocol and his vision improved from 20/40 to 20/20 with stable keratoconus and much improved topography. 450 microns is the limiting factor for Athens protocol. But usually keratoconic corneas are thinner. So how to improve visual outcome in these patients? Can the method of epithelial removal itself help us? For that, let's understand the pattern of epithelium in keratoconus. Reinstein et al. Demonstrated that in keratoconus, epithelium has a donut pattern characterized by localized central thinning at the cone apex. We hypothesized that if we use 50 microns of transepithelial PTK ablation to remove corneal epithelium during CXL, this differential epithelial thickness will work as masking agent. In this way, PTK will not only remove the thin epithelium, but also smoothen the underlying anterior stromal surface. This will further regularize corneal topography and improve visual outcomes. In this case report published by us, notice correlation between preoperative steep topography, localized ablated stroma, and topographic improvement postoperatively. Further, this combination, now known as Crathan protocol, was compared with standard CXL in series of 38 eyes. Our study demonstrated significantly better visual and topographic outcomes with Crathon protocol compared to CXL alone. This 22-year-old patient with advanced keratoconus, corneal thickness of 420 microns, and a high topographic astigmatism presented to us with suboptimal vision. Both Athens as well as Crathon protocol will not work in this case. This scenario is best suited for combining intracorneal ring segments as topography-enhancing procedure with CXL. Intracorneal ring segments act as passive spacing agents that flatten cornea and improve corneal topography. In our patient with advanced keratoconus, we used Intax SK, which has a smaller optical zone and much enhanced flattening effect, and then combined it with CXL to achieve topographic astigmatism reduction from 15 diopters to 7 diopters and visual improvement from 20/100 to 20/40. So after dealing with mild, moderate, and severe astigmatism, what about keratoconic eyes with high myopia but minimal irregular astigmatism that is very typical of central cones? This 27-year-old female patient presented with progressive keratoconus with a thin cornea of 427 microns, a good spectacle-corrected visual acuity of 20/30 with a high myopic astigmatism of -12 diopter sphere and -4.5 diopter cylinder at 180 degrees. We performed CXL, and after 6 months of stability, we implanted a toric phakic IOL, achieving an uncorrected vision of 20/40 from preoperative counting fingers. Selection of adjuvant refractive procedures has to be individualized depending on the patient's characteristics. 2 or more refractive procedures can also be combined with CXL in suitable patients. CXL Plus is probably the way to the future, a method which offers a complete treatment that is stability and functional vision together in keratoconus. So, refractive surgery in keratoconus? Yes, we are serious.